Now, don't run away, because the first question we've got is about phosphate removal. So if we think about the medium cutoff membranes, they're essentially working by diffusion with a degree of internal filtration, and therefore time is important with diffusion. Whereas when we're talking about hemodiafiltration, we're talking about convective losses, and therefore they're dependent on blood flow. So there are two different ways of doing dialysis. So the question somebody's asked Professor Madwell is this: they have a patient whose phosphate levels have increased, switching from an Elicio membrane with hemodiafiltration to the medium cutoff Elicio membrane. So why do you think the phosphate levels may have gone up?
Yeah, in my opinion, and in results of our study, we obtained similar results in all the low molecular weight solutes, and phosphate was around to 60% in all the treatments. I think that all dialyzers nowadays obtain a good diffusion, a clearance, and the differences should be in the medium and high molecular weight. When we compare, for example, in the post-dilution HDF treatment that increase a little the phosphate in the clearance, we didn't obtain differences in a medium large time, because sometimes it's compensated by the intake of more proteins and difference, but there are very few differences in the clearance. In my opinion, we have to expect a similar removal of phosphate.
So one of the issues, though, is that with diffusive clearance, time is actually important, and with convective clearance, blood flow is important. So sometimes I think with these studies, we're not comparing, we're not using the optimal treatments in terms of blood flow and timing, which may account for differences in results. So let's turn to Professor Panici, if I can. And one of the questions for you, Professor Panici, is which of the inflammatory mediators do you think is most important in terms of patient prognosis?
I have to divide the answer in two parts. From a clinical point of view, I believe that C-reactive protein and interleukin-6 are now the most reliable and easy to be measured in a clinical setting. If you want to speak about research and new molecules, I am very fond of CD40 ligand. And I think that is one of the most interesting new molecules, because what we are looking now is molecules that can be considered either maker and markers. So not only markers of damage, but also maker of cardiovascular disease and atherosclerotic process. And CD40 ligand is a quite interesting molecule to be measured.
Okay, well, thank you very much. Now let me turn to Dr. Martinez. So somebody in the audience has asked, could you elaborate a little bit more on what type of patients you think benefit from, say, hemodiafiltration, and what patients benefit from medium cutoff dialyzers?
Well, in my opinion, I think that patients that better can benefit from medium cutoff dialyzers would be patients unable to achieve an efficient convective transport volumes with online hemodiafiltration. In general, I think that is better hemodiafiltration, but in these patients that you can achieve this convective transport, it could be better medium cutoff dialyzers. And with the results of our study, I think that patients for whom albumin loss is particularly significant, it will be better the dialysis with Elicio HX, because the albumin loss was less than with others. And what these patients could be perhaps with frailty patients and patients with sarcopenia, or patients with malnutrition, hyperbilirubinemia, with inflammation, malnutrition. This is the we see.
Okay, well, thank you. So, can I to Professor Arby? So, in Japan, you've obviously had the super high flux dialyzer for some time, whereas in Europe, we've only really had the so-called, well, first of all, high cutoff and middle or medium cutoff dialyzers for the last couple of years. So, in terms of the data you were showing us, quite a lot of the data was 10 years ago, and the second set of data was about 5 years ago. So in terms of your super high flux dialyzers that you're talking about, how do they compare to our middle cutoff dialyzers? Okay, I've just been told Professor Arby's not on the line. Sorry, I apologize for that. So can I go back to Professor Madwell? So Professor Madwell, you were in your big study, you were showing us that patients were dialyzing for about 5 hours and had a high blood flow. So somebody in the audience has asked, well, how would the clearances change if somebody dialyzed for, say, 4 hours, so shorter time, and had a lower blood flow, let's say 300 mils a minute? How would that change the balance between the middle cutoff membrane dialyzer and hemodiafiltration?
This question we made 3 or 4 years ago, and we made a study with 250 milliliters per minute of blood flow, and we went to compare hemodialysis with pre-dilution HDF, with post-dilution HDF, and with medium cutoff dialysis. And this was a thing in the Japanese people that they use this blood flow and in a high percentage in the pre-dilution HDF. And the results was the best removal was observed in a post-dilution HDF. And in the second position, the medium cutoff dialyzers. And in the third, the pre-dilution HDF, and finally, the high flux in hemodialysis. Then I think the blood flow is very important for in my opinion, to obtain the maximum diffusion, the maximum convection, and also we can detect very quickly the fistula dysfunction. This is the several advantage of this high blood flow. And another point is the dialysis time. The dialysis time, the duration of the dialysis is for us is very important to achieve a better tolerance during dialysis and to obtain a plus removal. Probably it's not 5-10% with additional hour, but the tolerance of the patient is really very increased in our patients. This is my opinion.
Okay, and there's been a more specific question, Professor Madwell. So in some machines, the dialysate flow is split between convective volume and the dialysate. So if it's set, let's say, at 500 mils a minute, and you're getting a convection volume of 100 mils a minute, the net dialysate flow will be 400. In other machines, it'll be set at 500 mils a minute for dialysate flow, and let's say and convective flow 100 mils a minute. So in terms of your systems, what was the dialysate flow at the same time?
Well, we have another study 2 or 3 years ago that I remember we compared the dialysate flow 300, 400, 500, 600, and 700. And we can obtain similar results in convective volume. However, the diffusion, urea and creatinine, was slowly higher when we increased the dialysate flow. When we prescribe dialysis duration of 5 hours, we need only use 1 cartridge of bicarbonate, and then we need to reduce from 500 to 400 to maintain only 1 cartridge during the treatment. But the results was very similar in all the beta-2 microglobulin or higher molecular weight solutes. Only 1-2% differences in the urea or creatinine by diffusion, as it is expected.
Okay, and then can I turn around to Dr. Martinez? In your studies where you were looking at albumin loss, how did you measure albumin loss? Because there could be albumin loss into the spent dialysate, and there could be albumin loss due to adsorption to the dialyzer membrane.
Albumin loss was collected at 4 points during the session. Of course, it will be more correct to perform a continuous assessment of albumin loss like made Dr. Maduel, but we didn't have the proper methodology for this. But to check what we did, we averaged the albumin collected at the 4 points, and we checked if there was a difference in the area under the curve between the linear function and the logarithm function with the 4 points, and the difference found was minimal. And we think that is a good approximation to measure the albumin loss.
Thank you for answering that question. Now, Professor Panici, you mentioned that there are a number of different types of uremic toxins, and you alluded to protein-bound toxins. So how do you think hemodiafiltration and medium cutoff membranes would have any effect in terms of clearing protein-bound toxins?
It's difficult to answer this question. We need much more studies and experiments. We have tried to look at hemodiafiltration, high volume hemodiafiltration in a previous paper a few years ago, and a good removal of uremic toxins, protein bind was obtained, but we need much more data to answer this question.
Okay, well, I think that we've had a very interesting afternoon. We've heard some very interesting talks from Japan and obviously from Europe. And what we've learned is that there is a difference in patient outcomes, particularly patient survival, with different dialyzer membranes. And the membranes which allow us to remove more of the so-called middle-sized molecules have an absolute distinct advantage for patient survival. The question is how best to dialyze patients. And we have two ways of trying to remove these middle-sized molecules. One is by hemodiafiltration, and one is by using a diffusive technique with a so-called middle cutoff dialyzer. And what we've heard today is that most of the evidence in the studies that have been presented today show that similar clearances can be achieved with both methods. Now, obviously, there are some differences in terms of hemodiafiltration, in terms of the type of machine that's required, and additional substitution line. So, and again, as Professor Maduel's commented on, it's very important to get a high blood flow to achieve adequate convective volumes for effective convective clearance. So not all patients will be able to achieve high blood flows, and so in those patients, medium cutoff membranes may be the preferred option. And thank you all for your attention. And we should thank the sponsors, Nipro, for inviting the speakers and putting together this afternoon's symposium. And thank you for your attention, and good afternoon.
Good afternoon.
Thank you. Thank you, everyone. On behalf of Nipro, I would like to thank our moderator, Professor Davenport, all our speakers and all of you here and online for your interest and for your attention. Please do follow us on social media, on our website as well, to stay updated on our future events, our products, or for any inquiry on Elisio HX. So we will see you next time in the next NIPRO event, and I wish you a wonderful afternoon. Thank you. Bye.